Saudi Society for the kind invitation, and Dr. Khaled Khamisi. It's a privilege to be here. I'm going to speak about a subject which is still really debatable in my opinion, despite the new guidelines put in 2017, which seem to have settled this debate, but I think this debate is still going on. The incidence of ischemic mitral regurgitation is quite high. Around 50% of the patients suffering from myocardial infarction would suffer from some degree of mitral regurgitation, and nearly 10% of those would have some sort of moderate to severe mitral regurgitation, with the consequences of this mitral regurgitation on their event-free survival. This is the 2017 guidelines, part of it. I'm going to keep the second part till the end of my presentation, but basically what they're saying that if the patient is going for CABG with moderate to severe mitral regurgitation and his ejection fraction is higher than 30%, it's class 1 indication, and if ejection fraction is lower than 30%, it's class 2 indication, and it is debatable whether to take the patients without evidence of proper revascularization to surgery if his ejection fraction is lower than 30%. What we're doing to these patients for the last 20 years, that most of the surgeons are trying to repair the mitral valve, and this was the common practice for all of us. This is the results of one of the recent studies published, the randomized studies published. We had a 50% recurrence at 2 years for the patients who had mitral valve repair, and this was obviously is not a good result. But looking back at different meta-analyses performed, this is a meta-analysis published 2011, there was a favorable outcome for patients doing mitral repair over patients doing mitral replacement in this subcategory of patients, whether in the short-term survival or the long-term survival. And that was clear in many studies published in thousands of patients. Again, a more recent meta-analysis performed in observational studies, basically, and only one RCT study. And this showed, again, a preferable results in the early mortality and in the late mortality for the repair patients. To settle this debate, in 2012, there was a randomized control studies called CTSN study, and this study randomized 125 patients in each arm, and in this study, the patients had either mitral ring annuloplasty plus CABG, and supposedly they should have a sub-valvular procedure for severe tethering. And on the other arm, they had mitral valve replacements with complete sub-valvular preservation in the second arm. And they looked at the outcome at 1 month, 12 months, and 24 months. And the primary outcome was the improvement at the left ventricle, is indeed indicated by the left ventricular end-systolic volume index at these dates. Actually, the population they included in the study were quite sick patients. These patients had really big hearts, as indicated here. They had the ejection fraction of mean of around 40, and they had previous concomitant procedure. Most of these patients had concomitant procedure performed, and most of these patients had long cross-clamp times and long bypass times. So these really are sick patients in this study. And when they published the results at 2 years, they found out that the patient who had repair, this yellow line, the primary endpoint, the left ventricular end-systolic volume, improved at 1 year, and it kept improving at 2 years, whereas the patient who had mitral valve replacement, there was also an improvement at 1 year, but this did not show any further improvement by the second year. But basically, there was no significant difference in the primary endpoints. So they looked at the ejection fraction. The ejection fraction dropped in both groups at the first year, but it started to pick up in the repair group, and again, there was no significant difference. And they looked at the mortality. There was no difference in mortality. There was a bit higher mortality in the replacement group in the early period, as most of our experience indicates previously, but this at 2 years actually equalized, and there was no significant difference. And when they looked at MACE, again, at 2 years, there was no significant difference between both groups. And the quality of life scores, again, was not different by 4 different scoring systems. The only difference was the cumulative failure of mitral valve repair at 2 years, and that was really very significant. There was around 60% failure in the mitral, whereas only 3.8% in the replacement. So, as a result of this increased incidence of recurrent mitral regurgitation, the heart failure was significantly higher in the repair group, and the cardiovascular-related hospitalization was again significantly higher, but there was no difference in mortality, reoperations, MACE, or quality of life. So as a conclusion from this study, at 2 years after either mitral valve repair or replacement, actually what they concluded was put in the 2017 guidelines, and this reads if it is reasonable to choose chorder-sparing mitral valve replacement over downsized annuloplasty repair if operation is considered for severely symptomatic patients with chronic severe mitral ischemic regurgitation and persistent symptoms despite optimal medical therapy. And this conclusion would indicate for us as surgeons, we just go ahead and do mitral valve replacement for all these patients. And I think this is not a fair conclusion because, and I don't think I wouldn't follow actually these guidelines. The mechanism of ischemic mitral regurgitation, most of the surgeons here know very well, but basically we have got very good predictors over the last 20 years of which patient would fail. And these predictors are either on the valve level, the ventricular level, or even the clinical predictor. If you go only for the clinical predictor, if a patient have a prolonged heart failure symptoms of more than 1.5 years, this is a predictor of failure of repair. You should replace these patients. But we have very good echo predictors of failure of repair, whether the mitral valve tenting area more than 2.5 centimeters, the mitral valve tenting height of more than 1.1 centimeter, and the anterior and posterior tethering angles more than 40, and interpapillary muscle distance more than 20. On the ventricular level, left ventricular end-systolic volume more than 145, and many predictors actually would tell us that this repair would not work. As a consequences, the sub-valvular techniques were actually adopted by many surgeons, and there are different sub-valvular techniques, either traction sutures or actually Gore-Tex tubes around the papillary muscle, approximating the 2 papillary muscles, and there are many sub-valvular techniques in the literature. And when we looked at the meta-analysis of studies adding a sub-valvular techniques, this reduced the recurrent mitral regurgitation in the patients if the patient had a sub-valvular techniques or only had a downsized ring. And there was no significant difference in early mortality or midterm mortality between both groups in the meta-analysis, but there was a trend toward improvement in these patients. If we look at this, go back to the same trial and looked at this curve and then reanalyze the data for the patients who had failure of repair and the patient who had a good repair, we found out that patient who had failure of repair, actually the left ventricular end-systolic volume actually increased, whereas there was significant difference in the first year. In the second year, the end-systolic volume index in the patient who had successful repair came down to 47 and then down again to 42 millimeters, and this was significant. So the patient who had a good repair had actually a better outcome. So for this trial, I think in the CTSN trial, sub-valvular intervention was only done in around 12% of the patient, despite the severe remodeling in their population as indicated by their high left ventricular end-systolic volume. Furthermore, the decision of severity of mitral regurgitation was estimated by effective regurgitant orifice area of 0.4, where the guidelines at 2017 is 0.2, indicating further that the patients were very sick. They did not comment on all predictors of recurrence of mitral regurgitation apart from the presence of infrabasal dyskinesia. High incidence of recurrence was then expected in this study. So I think as a proposed algorithm would cover exactly the same as the recommendations say, but this is the last part of this. I would go for an annuloplasty plus subvalvular repair if there is a predictor of recurrence there, or corridor sparing valve replacement at the end. Thank you very much.